Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, from today we are starting our discussion on the management of liver cancers. We shall discuss the BCLC staging system for liver cancers. And then in the subsequent episodes, we shall take each and every stage of the liver cancer and we'll discuss the options available and how we should approach patients with different stages of liver cancers, what should be the best optimal treatment offered to them. Remember, the treatment of liver cancer is not a single person job. It needs a multidisciplinary team approach, the tumor board approach, where you have the hepatologists, you have the interventional radiologists, the conventional radiologists, the liver surgeon, the oncologists, and associated members. And when all of these faculty, they reach a conclusion, because one size does not fit all in such cases, and every patient has its unique opportunities, unique challenges, and we need to identify those challenges and find out the opportunities to offer the best available treatment for those patients. So today is the first episode of our discussion on the management of liver cancer. Bismillah ar-Rahman ar-Rahim. On the 1st May of this 2025, in Antalya, the city of Turkey, in an international conference on GI and hepatology, I delivered a lecture on Barcelona Clinic Liver Cancer staging for HCC. How reliable is this in 2025? And I thought that we shall start our discussion on the management of liver cancer from this keynote lecture, which I delivered in the IGHF Antalya, Turkey. We know the Barcelona Clinic Liver Cancer staging system is widely used and reliable method for classifying hepatocellular carcinoma into different stages, guiding treatment decisions and predicting patient outcomes. This classification was given in 2015, and in 2022, we had this updated version. The BCLC staging for HCC was developed in 1999, and this system incorporates factors such as tumor characteristics, size of the tumor, number of the tumor, and spread of the tumor, whether it has gone out of the liver or not. Then liver function, which is assessed by the Child-Pugh score. And we know this score evaluates bilirubin and albumin levels, blood clotting, and presence of ascites or encephalopathy. Then the performance status, which is measured by the Eastern Cooperative Oncology Group, which is called ECOG scale, and it grades a patient's overall health and ability to perform daily activities. The BCLC system categorizes HCC into 5 stages. Stage 0, which means a single tumor, less than 2 centimeters, with a normal liver function and performance status. Then stage A tumor, which is up to 3 tumors, each less than 3 centimeters, with normal liver function and performance status. Remember, in stage 0 and stage A, the liver function is normal, and performance status is normal. Sorry. Then stage B, when there are multiple tumors, but the liver functions and performance status are normal. Then stage C, cancer has spread to blood vessels, lymph nodes, or other organs with impaired performance status. Now the performance status is impaired. In stage 0, A and B, the performance status is normal and the liver function also near to normal. Then stage D, which means severe liver damage or impaired performance status. So primarily if a patient has severe liver damage or impaired performance status, irrespective of the tumor number and size, that patient falls in stage D. The BCLC staging system has undergone updates with 2022 revision providing more precise guidance on treatment options and prognosis. Its reliability and effectiveness have been validated by various studies, including a 2005 University of Michigan cohort study, which demonstrated that BCLC's highest independent power of survival prediction compared to other staging system. And this is the power and beauty of this staging, that it gives you prediction about the survival. Overall, the BCLC staging system remains a crucial tool in managing HCC, enabling healthcare providers to make informed decisions about treatment strategies and patient care. This was the initial staging, which was the algorithm published in 2015, where it was divided into stage A0, A to C, and stage D, and different options were given. And even in that, along with the different options, the predicted survival was given in this staging system. And then this 2022 updated version, it incorporates the prognosis, which is based on the tumor burden, liver function, and physical status, also redefined by alpha-fetoprotein, LB score, and Child-Pugh scoring. And then the patient's characteristics are very important, and they incorporates different characteristics. Then the treatment options, the first treatment options like ablation, resection, the ablation, then of course the transplant, systemic therapy are best supportive care depending upon the stage, and expected survival is also given more than 5 years, then 2.5 years, and about 2 years and 3 months, and of course when there is the clinical deterioration and decision making. So it is seems to be a complex, but when we will discuss in the subsequent episodes different patients with different stages, then you will find it very comprehensive and very elaborated. So the reliability and relevance of BCLC in 2025. As of 2025, the BCLC staging system remains one of the most widely used and clinically validated frameworks for staging HCC and guiding treatment decisions. However, like all staging systems, its utility has strengths and limitations. So the strengths of the BCLC, right, in 2025, one is comprehensive framework. It integrates tumor burden, liver function in form of the Child-Pugh score, and performance status, offering a multidisciplinary view of HCC. Then the treatment guidance. It provides clear treatment recommendations for each stage A to D, aligning well with evidence-based management strategies. And the prognostic accuracy. It performs reliably in predicting patient outcomes, especially in early to intermediate stages. And the global adoption, it is endorsed by major guidelines like those of EASL, AASLD, making it a common language among oncologists, hepatologists, and surgeons across the globe. What are the limitations and the criticism in 2025? One is one-size-fits-all approach. Critics argue that BCLC can be too rigid, lumping heterogeneous patients, especially in intermediate and advanced stage, into broad categories. So this is the one criticism on BCLC nowadays. Second is underestimation of curative options. BCLC traditionally limits curative options, that is resection, ablation, or transplant, to early stages. Though newer studies support expanded criteria for surgical resection and transplant in select intermediate stage patients. Third limitation or critic is that poor presentation of new therapies. The system has lagged in integrating recent advances like immunotherapy combination, itolizumab and bevacizumab, and TACE plus systemic therapy combination. But we hope that as the new studies and robust data comes, these will be also incorporated into the future version of BCLC. Fourth is the lack of molecular stratification. Unlike some newer models, BCLC does not incorporate tumor genomics or molecular markers, which are increasingly relevant in precision medicine. And we hope in the future update of this BCLC, these may be included. So the recent enhancements and adaptations. Updated versions of BCLC like BCLC 2022 update have started incorporating treatment stage migration and personalized approaches, acknowledging the fluid nature of clinical judgment. This is a very important point. Some clinicians now use modified BCLC versions or combine it with other models, that is ALBI score, Hong Kong liver cancer, or Italian liver cancer, for more nuanced decisions. The bottom line, how reliable is BCLC in 2025? Still reliable and useful, I understand, especially for standardizing care and staging across the globe. Best used is a framework rather than a strict algorithm. Clinical judgment, patient preferences, and emerging data often necessitate deviations from strict BCLC guidance. In academic and high-volume centers, hybrid or tailored models are gaining popularity for fine-tuned decision-making. Strengths and limitations in real-world HCC management, let's see that. Case number 1, the early stage BCLC, but transplant refused. 64 years old male, 2 nodules of less than 3 centimeter, and child P7 BCLC-A. BCLC recommendation is transplant in this patient. Clinical reality is that transplant was not possible due to lack of donor availability and patient refusal. So the RFA was performed as bridge therapy, and the outcome is that local recurrence at 14 months, but managed again with TACE. So the implications from this case, which has been reported in the literature, is that BCLC-A assumes transplant access, but real-world limitations necessitates alternate strategies. Case number 2, intermediate stage BCLC-B with surgical resection. 62 years old male, single large HCC 7.5 centimeter with well-preserved liver function, child PUG A and ECOG 0. BCLC classification, it recommends that in BCLC-B, standard recommendation is that of TACE. The clinical decision was done by a multidisciplinary team and it opted for surgical resection. And this was based on tumor localization in one lobe and no portal hypertension. So the excellent performance status was the third reason why they decided to go for surgical resection. The outcome of this case was that successful R0 resection, disease-free survival 18 months. So the implication from this reported case history is that BCLC-B would have recommended palliative TACE, but resection provided a potentially curative outcomes, and it shows the need for treatment stage migration. Case number 3, which has been reported in the literature, advanced stage BCLC with good response to immune therapy. A 58-year-old woman with HCC and segmental portal vein thrombosis, preserved liver function, child puke A with ECOG1. BCLC classification says it lies in C and it recommends standard recommendation of systemic therapy. Treatment given was atezolizumab and bevacizumab. Response was partial radiological response after 4 cycles. The downstaging allowed TACE and radiofrequency ablation. And the outcome was that stable disease at 2 years with excellent quality of life. So the implications from this reported case history is it shows flexibility in combining therapies even in advanced stages, contradicting older BCLC versions that restrict curative intent to early stages only. The case for BCLC-B with immunotherapy instead of TACE. 70-year-old female with multifocal HCC, 5 nodules, child puke A, BCLC-B. Standard recommendation is TACE. Clinical approach, due to borderline renal function and TACE-related risks, systemic therapy, atezo-bev was started first. Response was good response followed by TACE for residual lesion. And the implications from this case history are that it suggests a reversal of standard sequence, systemic first, loco-regional second, not originally covered in BCLC. So, Barcelona Clinic Liver Cancer staging for HCC. These cases highlight that while BCLC is still a helpful starting point, personalized management based on tumor radiology, liver function, and evolving therapies is key. Many centers are now adopting flexible stage-migrated approaches with better outcomes. So, this algorithm in 2022, it divides the patients into different stages: very early stage, intermediate stage, advanced stage, and terminal stage. And then depending upon the liver status, you allocate them for different therapeutic modalities. We shall discuss this in the subsequent episodes, and we'll take each and every one in turn. So here I'll discuss with you the filter approach. In the clinical practice, how you allocate your patients into different staging. When a patient presents to you with HCC, first step is check the CTP score and ECOG status. And depending upon this, if your patient is in child class C or performance status 3 and 4, this patient needs just palliative care. He or she is in the stage D and no heroics should be done. If in the first step you find that patient has got child class A or B with a performance status 0 to 2, then the next step comes, and this is the tumor spread. Remember that majority of your patients will fall here, but in less than 40%, if the patient falls here, then the second step is see the tumor spread. If the tumor spread has happened, it's present, it's outside the liver, then it's the systemic therapy which you need to give to these patients. But if there is no tumor spread in the second step, then comes the third step, that is the Milan's criteria. You go and you look for the Milan's criteria. In the Milan's criteria, if it's outside Milan's criteria, that more than 3 lesions or 3 lesions but bigger than 3 centimeter, the tumor is bigger in size, then you go for the it's the BCLC stage B. Predominantly the patient needs stays, but even in the treatment migration approach, they may be considered for the liver transplants, or even at times they may need systemic therapy. But if they are within Milan's criteria, then of course you go for they are in BCLC-A, and you go for a resection, liver transplants, or RFA, that is the curative approach. So dear colleagues, the key takeaways from today's discussion is that BCLC remains globally recognized as the most widely used staging system for hepatocellular carcinoma, integrating tumor stage, liver function, and performance status. It's a validated and structured algorithm. It provides a clear evidence-based roadmap for treatment decisions from curative to palliative options. And of course, rigidity is a limitation. In 2025, clinical practice often exceeds BCLC boundaries, particularly in intermediate stage B and advanced stage C, where treatment choices are more nuanced. And stage migration is common. Many patients benefit from out-of-range treatments, resection in BCLC-B, ARTACE, and immunotherapy in BCLC-C, which improves outcomes beyond guideline suggestions. Fifth takeaway is that the BCLC 2022 update, it introduced a treatment stage migration, offering more flexibility and alignment with real-world decision-making. The personalization is the future. I understand, and I think advances in immunotherapy, biomarkers like ALBI, and multidisciplinary care are shifting HCC management towards individualized dynamic models. And the clinical judgment is crucial. BCLC should be viewed as a guide, not a gospel. Optimal care requires tailoring decisions to each patient's unique profile. And emerging alternatives, other models like Hong Kong liver cancer, Italian liver cancer, and AI-based tools may complement or enhance BCLC in selected populations. So by this, I end here. Thank you very much for being with me. In the next episode, we shall discuss when a patient presents to us with stage D, what should be our approach. And similarly, in each event, we will discuss patients in different classes, stages, and see what should be our approach to these patients. And after covering these different stages, we shall review these staging systems, the treatment options, and we shall discuss the future opportunities for these patients. So see you in the next episode of liver cancer management, and we shall discuss when a patient presents to us with stage D, what should be our approach. Till then, take care.